Yeah, I got it. Does
Perfect.
everybody see this?
Yes, we can see it.
Okay, perfect. Thank you for the introduction, and thank you everybody for being here on your busy Friday nights. We'll just do a brief overview and hop right into it so we can get to the Q&A and let you guys out of here. Audrey's just going to be going over a brief review of some anatomy and pathophysiology regarding the paper, and then I'll talk about the findings themselves, what it really tells us, and why we should be using it to guide kind of some of our practices, and then we'll open it up for questions at the end. So I'm going to pass it over to Audrey.
Okay, so I'll just be going over a little bit on the epidemiology of resistant hypertension. So resistant hypertension is a condition in which blood pressure remains high despite the use of 3 or more antihypertensive medications. And today, 48.1% of the US adult population have resistant hypertension, but only about 20% actually do have their blood pressure under control. And there are many things that can contribute to this chronic illness, such as genetics, obesity, excess alcohol or sodium intake, and also lifestyle factors such as lack of physical activity, and demographics such as older age can contribute to resistant hypertension. Okay, and now I'll just be giving a little bit of background on the anatomy of the renal nerves. So the renal sympathetic nerves are distributed around the circumference of the renal artery within the adventitia and the periadventitial soft tissue. And neural recognition markers applied to renal sympathetic nerves have further revealed the nerve composition, revealing a mixture of efferent and afferent nerve fibers. And the proximity of these nerves to the renal artery allows them to be part of many percutaneous catheter-based treatment options, specifically aimed at the ablation of renal nerves for the treatment of resistant hypertension. And now I'll be talking about the anatomy of the renal vasculature. So the renal arteries do come off the aorta and they do supply the kidneys. So anteriorly, the proximal portion of the right renal artery is related to the inferior vena cava, while the distal portion is related to the shorter right renal vein. These structures separate it from the second part of the duodenum and the head of the pancreas. And posteriorly, it is associated with the right renal pelvis and the ureter in its distal section. And the left renal vein separates the left renal artery from the body and the tail of the pancreas and the splenic vessels. Posteriorly, its proximal part is related to the left crus of the diaphragm, the left psoas major muscle, the left sympathetic trunk, and the body of the second lumbar vertebra. The distal portion is related to the left renal pelvis and the ureter posteriorly. And knowing the importance of these anatomical relations is especially important for surgeons because certain structures can be injured when you approach the renal arteries. Okay, and now here's just some information on the pathophysiology of renal denervation in patients with resistant hypertension. So the sympathetic nervous system does play a role in regulating blood pressure via something called the sympathetic tone. And in patients with hypertension, there is increased sympathetic nervous system and renal sympathetic nerve activity, which does lead to higher blood pressure due to things like renal sodium retention, renal vasoconstriction, and increased renin release. Another important thing to know is the renin-angiotensin system, which is a hormonal pathway. So first, renin gets released when the kidneys notice a drop in blood pressure, and this triggers angiotensinogen to get released by the liver. Angiotensinogen is then converted to angiotensin 1 by renin. The angiotensin converting enzyme, or ACE, converts angiotensin 1 to angiotensin 2. And angiotensin 2 is the primary active hormone in the system, and it causes vasoconstriction and also stimulates the release of aldosterone. Aldosterone is produced by the adrenal glands, and this promotes sodium reabsorption in the kidneys, leading to increased blood volume. Angiotensin 2 also triggers the pituitary gland to release the antidiuretic hormone, which promotes water retention by the kidneys. Additionally, the sympathetic nervous system is also activated by angiotensin 2, which does further increase the blood pressure. So why renal denervation? It does minimize the risk of progression to organ failure, and it reduces severe and adverse hypertensive complications. And it is a good option for patients who are non-compliant with the hypertension medication regimen due to fear of side effects, forgetfulness, or financial constraints. And some contraindications of renal denervation that are important to know are people who have chronic renal failure and people who have had prior renal artery interventions, such as stents or angioplasty, and people who have anomalous anatomy as well. Okay, and now I'll just be going over the procedure protocol. So prior to renal denervation catheter activity, some operators do administer a vasodilator intraarterially in an attempt to prevent or minimize vasospasm. However, some operators don't do this because the prevention of vasospasm is questionable. So the first step of renal denervation is to access the site preparation, and a femoral artery is accessed under sterile conditions, usually in the groin, though other access sites may be used, such as the radial artery. A vascular sheath is also inserted to facilitate catheter placement. And the second step is catheter insertion. A catheter is inserted into the renal artery, and it is navigated through the aorta to the renal artery using fluoroscopy or other imaging guidance. And the third step is a mapping and navigation. So once the catheter reaches the renal artery, it is used to map the sympathetic nerve activity in the renal artery wall. The physician will then assess the location, the length, and the configuration of the sympathetic nerves before initiating denervation. And the fourth step is renal denervation, and the catheter delivers energy to ablate the renal sympathetic nerves, and this can be done via radiofrequency ablation, which I do believe is the most common technique, and it can be done via ultrasound ablation and also cryoablation as well. And the energy that is used to ablate the nerves is applied in a series of bursts or pulses along the length of the renal artery, and often targeting both the proximal and distal segments. And this procedure generally takes around 2 hours, but it can vary depending on the patient anatomy and the number of renal arteries involved as well. Okay, so here we just have some pictures of the renal denervation process. So in these images, 4 to 6 radiofrequency applications were performed in each renal artery with the irrigated catheter, starting at the most distal portion of the vessel, close to the bifurcation and towards the aorta, respecting the minimum distance of 5 millimeters between each application and the helical arrangement of them. And after each application, the catheter is pulled out and rotated with the aim of promoting sequential lesions in a helical configuration. So immediately after renal denervation, aspirin may be prescribed, but it's not to be used in the long term. And patients should then be observed for groin access or other complications according to local practice for comparable procedures, and this may involve an overnight stay. Patients should also be encouraged to maintain their ongoing antihypertensive medications unless they do have signs of postural hypotension, in which case they should contact their physician. And procedure follow-up should occur at 1, 3, 6, and 12 months after the procedure, and the endovascular physician should monitor office and out-of-office blood pressure to check for blood pressure control, potassium and creatinine levels, along with the blood pressure medication titration. Ultrasound imaging should also occur at 6 months to 1 year to check for renal stenosis, and finally, the physician should check for drug adherence periodically as well.
Fantastic. And we get to move into a little bit of the study itself now. So we're presenting the Spiral Hypertension On series, and they previously did a Spiral Hypertension Off medication series. And it's actually a subgroup analysis of these resistant hypertensive patients within the population described as having at least 3 antihypertensive medications. And the main focus of the study is that there's been recent literature suggesting that there are specific windows within the time of day that are associated with increased risk of adverse cardiovascular events. And it just so happens that these are early in the morning and kind of late at night preceding into that. And this is maybe an unfortunate pitfall from traditional just pharmacotherapy and how the regimen for antihypertensives typically is once orally in the morning So as we go about our day and begin to metabolize and excrete the drug, when is the plasma concentration going to be lowest? It's during this pre-waking period, so that might be why we're seeing some of this surge and is giving rise to uncontrolled pressures at this window. And this is really where renal denervation can step in and offer great benefit. Like I mentioned, it's a subgroup analysis at the 36-month check mark. And first they want to see, are we getting a gross mean reduction in 24-hour averages? And are we addressing these critical areas of time points in the study as well? And like I mentioned, this was a randomized, blinded, and sham-controlled study. There's some of the selection criteria listed on the screen. And again, this was the on-med series, so all patients were on 1 to 3 hypertensives at the beginning, and we're pulling from the 3 or greater landmark there. And it was 1-to-1 randomization for renal denervation to sham, and the primary endpoint of the original study was mean difference, the differences in means at the 6 months, and the clinical staff and patients were blinded through 12 months of follow-up. And for some of the technology that they were using Medtronic devices, the 4-electrode Symplicity spiral catheter, and the Symplicity G3 radio frequency generator. And just like Audrey mentioned, they were doing the same spiral pattern ablation as they retract through the main renal arteries, the accessory and branching vessels, and they were targeting vessels with 3 to 8 millimeters in diameter. And for the sham patients, they performed a renal angiography and had the patient remain on the table for about 20 minutes to give that essence. And for some check mark points, they ranged from 3 months to 3 years. And when they were checking the blood pressures, and they had patients taking their medications in front of the clinical staff, and they had to remain unchanged on their therapies for the first 6 months. And then at discretion, they were able to have up titrations if they needed. And there was repeat imaging sometime between 1 and 3 years for all patients for a reassessment of anatomical structures of the renal arteries. And there was eligibility for patients to cross over who were in the control group at 12 months at the investigator's discretion. And again, they're looking to see first, is this safe? And then secondly, is this working? Like I've mentioned, this is the subgroup analysis of 3 or greater antihypertensives for those that are deemed resistant. Baseline measurements were evaluated using t-tests, and follow-up changes were analyzed using ANCOVA and baseline adjustments. And there were actually 7 patients who were able to cross over, and they had to impute some of those values depending on when they left off. So that way they didn't omit their 36-month values, but at least had some sort of estimation as to what they could have been. And baseline recruitment was ranging from 2015 to 2017. It's a pretty small cohort with 23 patients in each group. They're mostly male, primarily from a white background. And I think another important feature is that some of the average BMI is elevated, ranging around 32 to 33. So it's not something to think about. But as we look at the bottom table, we can really see across the board in their baseline measurements of blood pressure that is very similar. There was no statistical differences between anybody and between any group, and there are some common comorbidities, but really no previous history of stroke or peripheral arterial disease. But one patient did have coronary artery disease. And finally, moving into some results, they've had some great depictions. On the left is our systolic, and on our right is our diastolic readings. We've got the critical windows, or the analyzed metrics at the top, and the blue is our intervention group, and the red is the control. So we can see that the red bars are coming down, and there is a reduction in their blood pressure readings, but it's far outperformed, even with the statistical significance, by the intervention group, and that's what they're portraying here. And this graph specifically is looking at these narrow windows at the nighttime and morning. So the nighttime was defined for the study between 1 and 6 a.m. and the morning between 7 and 9 a.m. And what they are looking for here is to see if there's a tighter control in the regulation of the pressure. So not only is there a gross reduction, but both curves were actually smooth, but the blue bar on the bottom was it had a more flat essence to it, recommending and suggesting that there was tighter regulation there, which is another great feature. And these help see the distribution of patients pre and post intervention, and in the control groups at 36 months. So on the left, A and C are the intervention groups, and B and D are the control groups. And just looking at A to start with, about 43% were in that range of 160 or greater, and another large majority, 30% in 150. And as we look to the right of that column, we're getting a much better distribution, many coming down into the yellow and even moving into the lighter and dark green, really getting quality control of their hypertension. And you just don't see that same distribution when you look to the right to B and D respectively. And this was just tracking the maximum and minimum recorded values. And you can see, again, another statistical significance between what is recorded in these reduction measurements. And the moving peak is within the windows of nighttime and morning. Whenever there was the greatest spike, they would take an hour range around that to help kind of minimize some of the major fluctuation with that. And again, across the board, you're seeing really great control and reduction of this in coordination with their antihypertensive therapies as well. And so what are the key takeaways? What should we learn from this? First, it's important that this is the first demonstration of really significant persistent reduction in morning and nighttime blood pressures across the board at a 3-year interval. Of most notably was the nighttime systolic, being able to get that under the 130 reading, and 80% of the intervention group compared to 49% in the sham. And as I mentioned, this is the most critical window associated with adverse effects. And across the board in the mean regulation, we're also seeing 40% in the intervention group as compared to only 6% in the sham. And there's great reduction and it's tighter regulated. These are things that are both key to management of this population. And I think in essence, this study is suggesting that not only we change our mindset and how in the metrics that we're choosing to evaluate these patients, but also shifting our clinical practice to be addressing these. And we've talked about the pitfall of the pharmacokinetics of antihypertensive therapies and how renal denervation can play a critical role in always being on when the patient needs it, especially when they are traditionally highest in their expanded regimen. So looking at the population, it really calls for a redefining of who should be considered and eligible for the procedure, because we've had great success from the off-med trial, and now with the original study ranging from more moderate ranges, and with this subgroup analysis to the highest risk kind of stratification of these patients. So across the board, we're really getting benefit, and it's revolutionizing where the field is going. And it's a safe procedure. There were minimally rare adverse events, and they haven't had to repeat any renal interventions at any point. Some considerations of limitations is anytime you're dealing with patients' adherence to medication regimens. And like I mentioned, it was a smaller study in the sub-analysis, about 23 patients. And when you have 7 of them cross over, that might take away from some of the power, but nonetheless, it supports, we got some really great data out of it. And further limitations are some lack of synchronization between sleep schedules, and the end kind of result of the study bled into the pandemic a little bit. And in general, there was the blood pressure control was not as great during that time. And just kind of looking at sub-demographics as well, mostly male, a lot of them from white backgrounds. So again, maybe the power isn't so great and who it can be applied to, but nonetheless, it should encourage us to be dedicating more efforts to this and considering where it can take us in the future. And these are our sources that help build it. Thank you everybody for being here, to the TNVIRJC board members for their efforts, and to Dr. Vatakencherry and everybody else for joining us today. But with that, we'll open the floor to discussion, anything you might want to know about the study or for our interventional radiologists in the session today.
Yeah, great job, great discussion, both on the kind of natural history of hypertension and renal denervation, as well as the data from the SPYRAL hypertension trial. I don't know, do you have anyone have any questions? And we kind of start addressing kind of a little bit on how I approach it or what I'm thinking as we approach this new intervention.
Hey guys, that was a great presentation. This is Kapil Wadamore, one of the IRs out in New York. I just had a question in terms of, are there any other endovascular specialists typically doing this besides IR? Or is this finally something that no one's going to steal from us?
No, I think just like a lot of endovascular things, anything with the cardiology, vascular surgery, VIR, all have a place in this. Hypertension is so common. So I think the key is this. The way I look at it is we're going to, young patients, age under 40, we want to definitely look for secondary causes. So I think the, aldo-renin ratios, obstructive sleep apnea, TSH, secondary renal vascular hypertension like FMD should all be interrogated. Subclinical or Cushing's or subclinical Cushing's, hypercortisolism. So we kind of have to do that workup. Then it's really what we're going to look at is we can't treat all these patients, but the ones that are on quote unquote like resistant refractory hypertension. So what does that look like? So basically, they should be on max therapy, usually a diuretic. It's often first line hydrochlorothiazide, chlorthalidone. Is usually kind of a first line agent, and then second, usually depending on the population, an ACE inhibitor, something in the renin-angiotensin system. So you're working on sodium and volume and fluid, and then renin-angiotensin, then a vasodilator such as a calcium channel blocker, usually amlodipine. So it's the three first agents that you should be strongly considered of. But in those patients who are still resistant or refractory when they're on those three or more meds, still difficult to control, then your risk of a secondary cause is pretty high. And so our population, we see about 20-30% of these patients with the quote unquote refractory, medically adherent, on optimized medical therapy with those three agents may have a hyperaldo. So that's an underdiagnosed and probably a higher incidence than we're seeing. So there again, it's very simple. Just take an aldo and a renin ratio. And if the aldo-renin ratio is over 30 and there's renin suppressed, that's indicative of hyperaldo. Now, it could be due to an aldosterone producing cluster cells, so may not even have an adenoma, but definitely something to consider. We could do a 1 mg dexamethasone suppression test, check the cortisol, do that at 11 p.m., check the cortisol at 8 a.m., and also gives you some idea, this is kind of a subclinical Cushing's, or is that contributing to it? You can check a metanephrine, the yield may be lower, but still, again, especially if there's an adrenal nodule, certainly consider plasma metanephrine pretty good sensitivity, TSH and whatnot. So once you've done that, you've checked femoral pulses, the rare quark, et cetera, you've covered most of your bases for secondary causes. And now you look at medical compliance and medical adherence. You look, you could do a single pill with triple medicine. So you can have like an ARB, a CCB, and a diuretic all into one pill. So something in the renin-angiotensin system, whether it be an ACE or ARB, a diuretic, like I said, like a hydrochlorothiazide or chlorthalidone, which is a little longer acting, and then a CCB or calcium channel blocker. So the single pill may improve medical adherence and compliance. So these are things that you start thinking about. Then, always want to consider dietary modifications. So if you look at the DASH diet, it dropped the systolic pressure substantially up to 11 millimeters of mercury. So kind of Mediterranean DASH diet is something that's also very effective in the population. And if you look at weight loss, and so you want the BMIs, and you saw the population had a high BMI. If you get the BMI, ideally less than 30, closer to 25, that can have substantial implications in both diabetes and hypertension. And so a 1 kilogram, which is 2-pound weight loss, is a millimeter mercury gain. So if you have a 5 kilogram weight loss, which is 10 pounds, you're talking a 5 millimeter mercury gain, which is pretty good, right? If you add that to kind of exercise, moderate intensity exercise, 10,000 steps, now you're also getting the gain of the exercise, the diet, the weight loss, will all have significant impact. So these are all things you'd be considering in these populations, right? Once you've excluded that, now you're like, okay, what's the next step? So again, we're not going to be able to treat anyone, but the patients who have very, higher risk factors like coronary disease, cerebrovascular disease, heart issues, heart failure, these more high risk patients, maybe AFib, et cetera, we can start to think maybe renal denervate them. 70% will respond, but there's 30% that are non-responders. And so you just have to counsel the patient on that. And it can take time for the effects to fully be present. So once you kind of sort these things out, it is something you can certainly offer patients, but it does, as I think Austin said, take some understanding of hypertension and the kind of core kind of foundation of it, whether class of agents, are they medically adherent, and feeling more comfortable with that component, and secondary cause workup and evaluation. We do a lot of, like you said, hyperaldo evaluation management, and I think that certainly helps us when it comes to being involved in this space. And I think we're going to see a lot more hyperaldo evaluation mainly because, again, a lot of these patients that have refractory hypertension or even resistant hypertension are undiagnosed primary hyperaldosteronism. And those may respond to spironolactone, or you do imaging and identify a nodule, or you do adrenal vein sampling to see if it's unilateral production or bilateral, and then can decide. So I think those are kind of the key things. Then you just work with your kind of, your colleagues in internal medicine, FP, extenders, et cetera. We're seeing these patients and kind of develop a hypertension pathway and work with your hypertensialists, whether it be nephrology, cardiology, whoever is in a passion and drive to kind of manage this condition is pretty impactful. So, if you look in the 1940s and, and earlier, when they had patients with resistant hypertension, there was really not a lot of medical options. So what they did was sympathectomy. They went in, did a big morbid surgery where they cut out the sympathetic plexus from the aorta. So that was, published and described, small series and small ends, but still done. And then later on, we had medications have gotten far, far better and continue to improve in its efficacy and safety. So that's great. And then really Simplicity was, hey, maybe this works. So they started off with Simplicity 1 and 2, kind of prospective, trials, and showed a benefit, right? They didn't do certain things. They did kind of office blood pressure, not ambulatory blood pressure. Ambulatory blood pressure, we think, is more significant and more relevant to cardiovascular outcomes, right? Because the main thing we're trying to do is reduce cardiovascular and cerebrovascular outcomes, along with end organ damage, whether it be the kidneys, the heart and vasculature, et cetera. So this was shown. Okay, so Simplicity 3, as I think Austin mentioned, was, again, the highest level of evidence when you're doing a sham trial, which is rarely done, right? Sham trials have been done in vertebral augmentation trials like Columese, Bushbinder, Vapor trial. These are all sham trials looking at kyphoplasty. That, again, or vertebroplasty, vertebral augmentation, same thing was done here. So you're putting someone under, the placebo effect of surgery is very high. Right. So when you put them to this, it's the highest level of evidence that can be derived. Right. So Orbita was done in the coronaries. So again, multiple beds. Now we're looking at these sham trials and what that means. It's hard to recruit. It's hard to do, but it is valuable data to say what's really going on. So Simplicity 3 was a negative trial. It didn't show a benefit compared to optimized medical therapy. Some of it was because we were getting better at managing hypertension. We're getting better at finding secondary causes. And these things. But as you follow these Simplicity 3 patients, probably medical adherence dropped, and these patients did have a longer-term durable effect. What we've also seen is, as this 3-year data shows, the continued efficacy, if they're a responder, continues to be effective, and there's this always-on effect, meaning it doesn't matter if it's 2 a.m. or 5 p.m., that effect is always there, whereas a pill has variation based on pharmacokinetics. So those things all matter. And nighttime or AM blood pressure is associated with higher cardiovascular events. So we can have an on effect then. It's great, right? Theoretically. Now, what we don't have, though we know that blood pressure drops, we don't know that we're reducing cardiovascular events compared to sham trial, right? We don't have that data. And really, when it comes down to it, it's just a number. What we're trying to do is reduce event rates. Can we prove that we can reduce heart attacks and strokes and other associated problems with hypertension? We're not sure. We think so, but we're not sure. And that's why the grading in the European Society of Cardiology is not like the first highest grade, because we don't have cardiovascular outcomes. It's like having weight loss without having the cardiovascular benefits, et cetera. It's going to be a different designation if you have a weight loss pill that actually has cardiovascular outcome benefits. It's the same kind of construct here. So it could be phenotypically reduced blood pressure, but it may not be genotypically, or it may not be clinically relevant. So I know it's a kind of long-winded answer, but if you understand the disease and kind of understand it from a global and perspective in the management, I think you'll have a space in there. But a lot of players will. I think there's a lot of hypertension. I think many players will be involved in this. A lot of the trials were run by kind of the IC. But I think it is something that we should all be familiarized with to get more comfortable with. It's such a common condition, that and diabetes and obesity and hypertension. These are 3 kind of the big things I think we can really help the populations with. Any other questions? But great question. How do we kind of have a stake in this, and why?
Do you think we'll get to a point where patient candidates go beyond just refractory to maximum medical therapy? Do you think this may be indicated just for
Yeah,
the mainstream moderate patient?
I think when you're doing population-based care, right, this is not a cheap technology, it's costly. We have to take the most bang for the buck, who are going to help and impact the most from a societal standpoint. And so I think initially we will drive it towards those high-risk patients who are going to likely get the most benefit. They're either intolerant of certain medications or can't take, some of these meds and they're still high. And they're, the ambulatory blood pressure, which you do 24-hour, you check, and they're constantly high. I think those are the patients we would start off with. But as the technology gets cheaper and we can offer this to more patients because of cost-benefit analysis and whatnot, then I think we will expand the role. And as we learn more, as we gather data, follow them, So if you look at simplicity, some of the original trials, we have longer and longer term data, from the original trials, which is pretty exciting.
Are people offering renal denervation outside of trials? Is this just being done like in private practice, for example?
Yeah, great question. So it's FDA approved. It's just a matter of the CMS and the reimbursement. So it's got a special code right now, but they're working to kind of, they're trying to figure out where, because it's pretty costly. So where will CMS kind of start to push the reimbursement? But yeah, it is. It's being offered. It can be done. It's just the reimbursement is going to be kind of variable depending on your insurance carrier and the clinical indication, et cetera. And CMS ruling from Medicare standpoint.
I don't know if I missed this, but is the efficacy of the alcohol ablation, I think it's the Peregrine device, is that comparable or thought to be similar to some of the other ablation devices? And also, do you target both sides at the same sitting, or is it a staged procedure?
So yeah, it's a good question. I don't know. I haven't seen I don't know the literature well in the alcohol denervation approach. Some people have done or with the needle and the ultrasound. So I don't know the answer to that. But yeah, usually bilateral. I mean, there's some anatomic configurations that are required. With the ultrasound, the balloon one, you just do the main renal artery. With the spiral, you have to go into the branches. And the reason why is the they did main, and what they saw in the anatomic test is that as you get further away from the main and into the hilar branches, the sympathetic plexus is closer to the vasculature. So in theory, by getting that, you're getting a better denervation of that from a theoretical standpoint. But that was kind of the rationale of the spiral and going further in than the ultrasound. So I'm really most familiar with those two technologies from the trial standpoint. But yeah, I don't know the answer to the alcohol.
And we talked about kind of the workup for who might qualify for this procedure. Is there a specific demographic that really is getting the bulk of it?
Well, time will tell, but again, the patients are multi-med with ambulatory blood pressure super high, with high end organ problems like CKD. Right now we're not doing the CKD population, but we're theoretically we could reduce nephrosclerosis in that possibility. We don't see it's fairly safe procedures. That's what we can say from all the trials that we've seen. I'd probably do that. They have high risk or cardiovascular events or hyperlipidemia. These other risk factors that put them at high risk for event rates is probably who we'll start off with. Or medical patients who just can't tolerate meds for whatever reason. The calcium channel blocker is causing too much swelling. The ACE or ARBs is causing some, there's too much of a cough or some other side effect that they just are intolerant of. At least for now.
Are you targeting accessory arteries as well, or is this just mostly for the main ones? And what's the size of the device?
Main renal artery. And once you start having accessory, it can be trickier. It can certainly be done, but it may be off-label, So, and transplants are not being investigated either. So we don't know if that'll help that population as well.
What's your approach to patients with concomitant like renal artery stenosis or atherosclerosis?
What?
And are they, are they rolled out for this kind of intervention?
Yeah, they were not part of the trial, so we don't know. So technically, I mean, theoretically it's possible, but I don't think it's not been studied. So we don't know.
Has this ever been done in the pediatric population? Just from my practice, we have every once in a while kids who we don't find any kind of segmental stenosis or renal artery stenosis in, and it's still kind of a mystery. So I'm wondering if this has been applied to that population.
Not that I'm aware of. I mean, certainly would be off label, but I have not heard of it being used in peds.
And kind of similarly, we've got data now showing up to 3 years of effectiveness, but is there kind of a greater stretch beyond that in what you're seeing in actual clinical practice?
No, so it just got recently FDA approved, but if you look, there are a few European and Australian data sets from, I think, the original trial that they collected and gathered, and they have up to, I think, 8 years or 6 to 8 years, and they're still having an effect. Again, some of this may be not just the effect of the therapy, but also medical adherence drops as time goes on, right? So medical adherence to any medication, hypertensive medications, even the obesity meds, they drop. So it's just the nature of the beast. It's hard to keep on taking pills, and remember to do it. Great. All right. Any other questions? Otherwise, Luke and Audrey, great job. Hypertension is a very common disorder. You need to get familiar with it. You're going to have a lot of patients with it. Dietary modifications. Look at the DASH diet. It's pretty good trial. Mediterranean DASH diet. Those kind of things work well. Exercise, right? 10,000 steps is a goal. Adequate sleep, and avoid smoking and alcohol, and the things that you were talking about really impactful, right? From a patient standpoint, dropping the BMI closer to 25 ideally is a goal that you should really all push for, right? So resistance in exercise training will really impact the global population, not just for this, but for diabetes and so many other conditions. So I think these are the key things to be thinking about. A lot of what we're seeing is probably related: back pain, knee pain. A lot of things that we're working on can be reduced, and that comes with you guys just counseling patients and learning more about it in med school. And this is just an important process that we can really reduce heart attacks and strokes by not only understanding the kind of the medical side, but the pharma side, but also now the interventional side. But it's a multi-pronged effect. Okay.
Awesome. Thank you guys so much, Luke and Audrey. Great job. Thank you, Dr. V, as always, for all the pearls and all the great questions, everyone else.
Yeah, thanks, everyone. Great job, guys.
Thank you, everyone, for attending. The recording for this will be up very soon, and hope you all have a great weekend. Take care.
Thank you, Dr. B.
Take care, everyone.
Thank you.